Hey, healthcare friends, do you dread doing your notes every day? Do you feel like you can never get ahead of charting? If you're shaking your head yes, keep listening. Freed AI is a medical scribe on a mission to free clinicians everywhere. Freed AI listens, transcribes, and writes medical documentation for you, written in your style and ready the moment the visit is over. All you have to do is give it to your patient. Just imagine leaving the office at the same time as your last patient. Freed is HIPAA compliant, secure, and takes less than 30 seconds to learn. Artificial intelligence cannot replace you, but it can do the administrative work that no human should be subjected to. Get back to doing what you love, helping your patients, and let Freed AI do the rest. Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. As always, go check out the top 200 drug study guide. Great refresher. It's a 31-page PDF on the top 200 drugs. Great refresher, great little item if you're preparing for pharmacology exams. Just some of the most important clinical practice pearls from every one of those medications. So go to reallifepharmacology.com. Subscribe simply by email. You get access to this. Definitely a no-brainer to have. All right, let's get on with the medications today. We are on 186 through 190. We are getting closer and closer to finishing up those top 200 drugs. So we've got Sonata. That is the brand name. Generic name is Zaloplan. This is classically referred to as a Z drug. As far as the classification, easiest way to remember is Z drug. They have a Z in them, and then also gives you the Z's, so it makes you sleepy. So, as you can imagine, the indication is insomnia. These are recommended, this class of agent, Zaloplan specifically as well, it's recommended for short-term use. Really important to utilize non-pharmacological interventions prior to trying any of these agents. Super important. And I've blogged about that on meded101.com in the past as well, if you Google search that. Mechanistically, Zaloplan binds to GABA at the benzodiazepine receptor complex. And this ultimately increases essentially GABA activity with the brain. If you remember GABA, it's an inhibitory neurotransmitter, so enhancing that effect, you get a more inhibitory sedative type effect on the central nervous system. Again, obviously we want a pretty quick onset of action, so this medication is going to start working within 30 minutes or so, give or take. It is a controlled substance. That's important to know, and that's really why we want to limit this to very short-term use, if at all possible, because there is a potential for addiction, abuse, dependence, all those bad things that go along with controlled substances. So again, limit the use, very short-term, so patients don't get dependent upon the medication. In our geriatric folks, this medication does appear on the Beers list. It's got a very similar profile to benzodiazepines. So again, that excessive sedation can worsen confusion, can increase fall risk. Also, when we add it on top of opioids especially, we can increase that risk for respiratory depression as well. So again, kind of summing up some of those adverse effects, sedation, drowsiness, obviously that's what we're trying to do with the medication, but we can have kind of those lingering effects into the next day, which can be problematic. Dizziness, confusion, can be some GI upset occasionally, not something I worry about too much there. Generalized CNS depression, of course. And then kind of the one unique one, there is a boxed warning on this. It's sleepwalking, sleep driving, kind of abnormal activities while the patient is actually still sleeping. Okay, so very important to remember that. Educate patients about that. I've definitely heard of cases of, sleepwalking, sleep driving, sleep eating. I've heard of as well, and obviously in some situations this is very dangerous. Think of sleep driving, sleepwalking. Definitely can be an issue. So important thing to remember, definitely something that could show up on a board exam or a final exam. with regards to these agents and the adverse effect profile. Drug-drug interactions, finishing up Zaloplan here. CNS depressant activity. I alluded to opioids already, other benzodiazepines, Ativan, clonazepam, so on and so forth. The older first-generation antihistamines, diphenhydramine. We've got gabapentinoids like gabapentin, pregabalin. Illicit drugs, some of the opioids, heroin, for example. Also things like cannabis. So any drug with kind of that CNS sedative type properties that can have an additive effect there. CYP3A4, there are some interactions here. Inducers can reduce effectiveness. Carbamazepine, St. John's wort. Inhibitors can actually increase concentrations, which ultimately increase sedative effects. And then think about those medications that may worsen insomnia, which we're trying to treat. Stimulants, steroids, caffeine. Making sure that we're not on those medications, or those medications aren't causing insomnia, which is causing a drug like Zaloplan to be prescribed. All right, moving on, we've got bisoprolol. The brand name is Zebeta. This is a cardioselective beta blocker. Mechanistically, by blocking beta-1 receptors of the cardiovascular system, we ultimately kind of suppress the action of the heart, which can be beneficial in certain disease states, obviously. So it can be used for hypertension, potentially atrial fibrillation. It does have an indication, or does have evidence to support its use, I should say, with congestive heart failure as well. Other conditions, chronic angina management, and then maybe more rarely like migraine prophylaxis. So can see bisoprolol in all those different settings. Adverse effect profile with the beta blockers, fatigue is something that does happen with patients. It's something I've definitely seen in practice. Dizziness can happen. I have seen some reports of cold extremities as well when somebody has started or increased the dose with this medication. With beta blockers, we got to be careful about abrupt withdrawal. Particularly if somebody's at moderate or high dosages, we can kind of have this, rebound or withdrawal tachycardia, elevations in heart rate, and potentially blood pressure there as well. So that's important to pay attention to. In somebody with an acute heart failure exacerbation, it could worsen that situation in that setting there as well. So a few things to think about with regard to adverse effect profile. Drug-drug interactions, there is some CYP2D6 metabolism, so CYP2D6 inhibitors may alter those concentrations a little bit with bisoprolol. And then other thing I think about are kind of additive effects. So we've got drugs that can cause bradycardia, so kind of pile on top of the effects of bisoprolol. So those non-dihydropyridine calcium channel blockers like diltiazem and verapamil. Rivastigmine or donepezil, these are acetylcholinesterase inhibitors. These can sometimes drop that pulse a little bit and add on to the effects of bisoprolol. And then, of course, we've got the blood pressure lowering effect with bisoprolol, so any type of additive effects there. Alpha blockers, ACE inhibitors, any type of antihypertensive, basically. Clonidine would fall in that category as well, as far as dropping that blood pressure too low. Clonidine may also increase that risk for bradycardia too. And then I do remember beta-2 agonists. So, if the dose of the beta blocker is high enough, if it's not as selective as we would like, there is potential that it could worsen respiratory status and blunt the effects of some of the beta agonists that we're trying to use, like albuterol or formoterol, for example. So that's something to pay attention to. In my patients, let's say I see bisoprolol started, what I'm looking out for is basically worsening respiratory status, and that might be indicative of an increased need for albuterol, elevation in doses of inhaled corticosteroids if we've got an asthma patient, or elevations in doses or more medications necessary to manage COPD. Keep an eye out for that, and when you see that, kind of backtrack and go back and look and make sure a beta blocker like bisoprolol hasn't been started or anything. Moving on, we've got Zovirax, which is the brand name. The generic name is acyclovir. This is an antiviral medication classified as a purine nucleoside analog. Can be used for herpes simplex virus, for example. Herpes zoster, you may see it used as well. Those are a few common antiviral type indications that you may see it used for. Now, I will say, probably one of the biggest reasons you see valacyclovir used over acyclovir, very similar medications, treat similar things for the most part, but valacyclovir we can typically get by with less frequent dosing. Acyclovir, need to take this medication up to 5 times daily. So as you can imagine, that could certainly be problematic for a lot of patients. Mechanistically, it prevents that viral replication. Ultimately, the purine nucleoside that gets converted to its active form, acyclovir triphosphate, that's done by viral thymidine kinase. Acyclovir triphosphate competitively inhibits viral DNA polymerase by mimicking deoxyguanosine triphosphate, terminating the growing DNA chain for the virus. So again, it being a purine nucleoside gets converted to acyclovir triphosphate, and that acyclovir triphosphate essentially messes up with the production of DNA by inhibiting DNA polymerase. So I alluded to that frequent dosing. That's one of probably the biggest reason why you don't see acyclovir selected over medication like valacyclovir, for example, as long as they're both indicated for the specific indication you're looking at. One other thing to think about with this medication is recommended to encourage adequate hydration. There's some increased risk for kidney problems if we don't give this with enough fluid. So definitely important to think about that. Other adverse effects, GI upset, that's probably the most common one you're going to see. Some general malaise, fatigue, you may see that as well. There are different formulations. There's ophthalmic and topical agents. So obviously with those topical type agents, we can have some irritation and that type of thing. And then probably on the more rare side of things, we can have some thrombocytopenia as well as that nephrotoxicity renal issue I mentioned as well. All right, drug-drug interactions. So first, I think about nephrotoxic medications, aminoglycosides, NSAIDs, maybe amphotericin B. I think that's important to think about, that kind of additive effect, that additive insult to the kidney. That's important to recognize there. CYP1A2 activity. Acyclovir is, to a certain extent, it inhibits CYP1A2. Probably one of the more common medications I've seen that this may increase is tizanidine. So concentrations could go up with this skeletal muscle relaxant, which can obviously lead to CNS depression, sedation, those type of effects there. If you're in the market for any pharmacist board certification study material like BCPS, ambulatory care, NAPLEX, geriatrics, MTM, go check out meded101.com/store. We've helped thousands of pharmacists prepare for their board exams and pass their board exams, and we believe we can help you too. So go check that out. It's a great way to support this podcast, and again, support the sponsor, meded101.com/store. All right, moving on, we've got warfarin. Brand name is Coumadin. This drug used to be used a lot more than it currently is. However, I see a fair amount of it still. This is an anticoagulant utilized in atrial fibrillation, pulmonary embolism, certain situations with prosthetic cardiovascular valves, and those, any type of situation where we've got a significant clot formation. Warfarin may be a potential option in those situations. Mechanistically, it inhibits vitamin K epoxide reductase, which blocks the activation of vitamin K and reduces the production of vitamin K-dependent clotting factors. And those factors, which often come up on pharmacology and board exams, are 2, 7, 9, and 10. Those are the factors that are impacted with the use of warfarin. So we've got high bleed risk, obviously, with this medication. Bruising, bleeding, definitely going to be the primary thing to think about there. Have seen hair loss reported, alopecia, so that's something to think about there. With the bleed risk, we do have a boxed warning associated with that, and to try to make sure that we're getting enough of the medication to prevent clots, but not too much. With warfarin, we monitor INR. For most patients, the goal is going to be 2 to 3. There may be some exceptions. Patients may be at very, very high risk of bleeding. I have seen kind of off-label goals of 1.5 to 2.5. Some indications may have a higher goal range. So, some of the mechanical prosthetic heart valves, we may shoot for a target of around 3. So maybe a range of 2.5 to 3.5 for the target INR. Typically, INRs are done on a monthly basis, and there are obviously going to be a ton of potential drug interactions with this medication. So, antibiotics, Bactrim, metronidazole, some of the macrolides like erythromycin, these can all raise concentrations of warfarin. Amiodarone, cardiovascular medication, can definitely raise concentrations of warfarin. There are herbal medications, even over-the-counter supplement-type medications. Garlic, ginkgo, these have been purported to potentially increase bleeding risk. We've also got some medications that may reduce the effectiveness of warfarin, enzyme inducers, for example, barbiturates being a common class of medications there. Also, we can have the food interaction with warfarin, definitely something you're likely to be tested on. Foods high in vitamin K, if that intake goes up, if it changes, we can ultimately reduce the efficacy of warfarin, which is ultimately going to reduce the INR, increasing the risk for a clot. Classically, we consider those leafy green vegetables, spinach, for example, having higher amounts of vitamin K. So if that intake changes, that could definitely alter the INR, and that's one of the first questions that somebody managing warfarin would typically ask if there's a noted deviation from their usual INR. Lastly, I do want to mention drug disease state interactions. So if a patient has like heart failure exacerbation, for example, diarrhea, hyperthyroidism, these may increase INRs and increase the risk for bleeding. Reduced INRs or efficacy, chronic alcoholism, that's a little bit kind of controversial how it swings the INR. But I think it just goes to show you that, significant changes, patients not feeling well, changing their diet, these can all have some interplay with that INR. And it's important to ask those kind of questions when you get an INR back that's 4.2. Hey, it's time to take a look and see what's going on, what's been changing, and what those potential changes did to that INR, and how we can get a patient back more consistently and within their target range. All right, moving on, we've got the last medication, that is Luvox. Generic name is fluvoxamine. This is an SSRI, it's an antidepressant, so you would anticipate that it's going to be used somewhat regularly in the management of depression, being an SSRI, which is usually the drug of choice. However, the biggest thing with this is drug interactions, and I'll get into that in the future here towards the end. Actually, the primary indication I see this used for is OCD. Again, can be used for depression and that type of thing, but OCD, occasionally some panic disorder, PTSD, I have seen this medication used for that as well. But again, not used very often at all. It does, similar to other SSRIs, it basically increases the levels of the serotonin neurotransmitter within synapses of the brain. It is on the Beers criteria for increasing sodium levels, and this is true of all SSRIs. There is a, I would say, fairly rare risk of that, but it can happen. And then rapid discontinuation, we want to avoid that in general. So if patients on a moderate to high dose abruptly discontinuing an SSRI, like fluvoxamine, can lead to some withdrawal symptoms, increase in irritability, sometimes even some GI upset, some confusion, headache, maybe even this sensation of brain zaps. That has also been reported as well. So again, important to pay attention to that when we're giving this medication to a patient. All right, adverse drug reactions, sexual dysfunction, important to think about. We can have some changes in sleep pattern as well as potentially some GI upset. Of course, we can increase the risk for serotonin syndrome. Again, incredibly rare there. That hyponatremia risk I mentioned as well. And then we've got that warning for increased risk of suicidal behavior and thoughts, especially in younger patients. That black box warning is still with this medication. All right, drug interactions. This is huge with this medication. So it's a strong inhibitor of CYP1A2. Aren't too many medications that this is an issue for. I alluded to potentially tizanidine earlier. That's probably the one I see the one used most commonly in practice. Theophylline is a respiratory medication. It's been a long time since I've seen that, so I wouldn't stress too much about that. We've also got some CYP2C19. We've got some CYP2D6 inhibition. With that 2D6, 2C19, I think about clopidogrel and tamoxifen. So CYP2C9 is very, very important. CYP2C19 is very, very important with the activation. Those are both prodrugs. So we could reduce the efficacy of clopidogrel and tamoxifen when using fluvoxamine. The serotonergic additive effects, SSRIs, TCAs, triptans, so on and so forth, so increased risk of serotonin syndrome, kind of an additive effect there. Bleed risk, I don't worry about a ton, but there is definitely some evidence and theoretical risk with increasing bleed risk. Obviously, antiplatelet meds, anticoagulants, NSAIDs, so on and so forth. And then QT prolongation, again, not crazy high on my radar, but is something to think about there when used in combination with other meds like amiodarone, antipsychotics, some of the macrolide antibiotics, for example. All right, well, that's going to wrap up the podcast for today. Thank you so much for listening. Do me a huge favor, share us with friends, colleagues, students, other healthcare professionals who could benefit from some pharmacology education. Leave us a rating review on iTunes or wherever you're listening. I greatly appreciate that. It helps us grow the audience. Support meded101.com/store. All purchases there go directly to support me continuing being able to do this podcast. So greatly appreciate the support there. Lots of different study materials, books for all different folks from pharmacy to nursing, med students, and so on and so forth. So Again, go support the sponsor, meded101.com/store. If you want to reach out to me, Eric Christensen, mededucation101@gmail.com, or you can track me down on LinkedIn as well and connect with me there. Thanks again for listening. Take care, and I hope you have a great rest of your day.